Good morning. The topic for today is acute flaccid paralysis. Okay. So, when we talk about acute flaccid paralysis, what is acute? Acute means it is a very short onset, that is less than 4 weeks. Okay. Flaccid, that means there is loss of tone or hypotonia along with absence of spasticity. Koncham door close this. Koncham door. Thank you. The term flaccid denotes the absence of spasticity and other signs of corticospinal dysfunction such as the hyperreflexia, clonus or extensor plantar response. So it will be acute, like we said, and usually less than 4 weeks of duration. Onset is less than 4 weeks of duration. Flaccid, that means there is no hypertonia or there will be presence of hypotonia, and there is absence of other signs of corticospinal tract dysfunction such as hyperreflexia, clonus or extensor plantar response, and paralysis. Now, if there is a weakness of a limb, okay, a partial weakness, then it is paralysis. But if it is a complete loss of movement of the limb, then it is paralysis. Okay. So what is the definition? When we are talking about acute flaccid paralysis, we have to be very clear as to the definition. So is any person or any child can be the criteria for inclusion? This is a case which is defined as any child who is less than 15 years of age and who has acute onset of flaccid paralysis for which no obvious cause is found. Okay. Or paralytic illness of any age, it could be 16 years old, 17 years, whatever, any age in which the polio is suspected. So all cases of AFP, regardless of the case of the age, should be reported and investigated as polio only. So we have to take first diagnosis as polio. So main thing is the background rate is of the non-polio illness is less than 1 per 1 lakh population. So what is the goal of AFP surveillance? The AFP surveillance is, so there should be reporting of cases such that the reporting should be so efficient that at least 1 case per 1 lakh population of acute flaccid paralysis is reported in children less than 15 years of age. This would ensure at least there is good efficacy or adequacy of surveillance. Now if a child comes with acute flaccid paralysis, what could be the lesion and where could be the lesion? Okay, so it could be either at the spinal cord, it could be at the level of the peripheral nerve, it could be at the level of the peripheral nerve, a neuromuscular junction, or it could be a muscle. So if it is in the anterior horn cell, or the motor neuron, so then the likely infections could be a polio or some other non-polio enterovirus or a neurotropic virus. If it is peripheral nerves, we can think of DDs like acute Guillian-Barré syndrome, porphyria, toxic neuropathies, any other collagen disorders. When it is neuromuscular junction, then it is myasthenia gravis, organophosphorus poisoning or botulinum, which act at the myoneural junction or the NM junction. Okay, or it could be a snake bite. Okay. And it could be only at the level of the muscle. That could be a periodic paralysis, okay, familial periodic paralysis, or hypokalemia, okay, and or any critical illness which can cause neuropathy or myopathy. Then comes spinal cord, acute myelopathy, okay, it could be a spinal cord infection like any viruses like rabies, herpes virus, HIV, bacteria like tuberculosis which can infect, a compressive myelopathy like epidural abscess, spinal cord infarction, tumors, or any idiopathic transverse myelitis. Okay. Now the main causes, and this is very important, the main causes and differential diagnosis of acute flaccid paralysis. So what could be there? So it could be, so first we said that any case of acute flaccid paralysis who presents less than 15 years of age, first thing which should come to our mind is polio. Okay, so if there is no polio, polio, what else it could be? It could be Guillian-Barré syndrome, it could be traumatic neuritis or transverse myelitis. Now, how do you differentiate these four main classes? So, etiology, like we know that poliovirus type 1, 2 and 3 and other enteroviruses can present like polio. Then in Guillain-Barré syndrome, which we will be talking later, it is likely to be a delayed hypersensitivity type of a reaction. Or it could be a immunologic phenomenon. Then traumatic neuritis, where we know that there is a history of trauma or an injection at that particular site. Or transverse myelitis, where usually the cause may not be known, but there is a predilection that some viruses could have caused this transverse myelitis. Now, once we can think of the etiology, when is the onset of paralysis? Usually within 24 to 48 hours in polio. It's an acute onset. Whereas Guillain-Barré syndrome, it may take few hours, but it will be a slow progression, like over 10 days or 2 weeks. It will be a slow progression. Traumatic neuritis is again few hours to a couple of days, like 4 days or something. Transverse myelitis also few hours to about 4 to 5 days. Then what about fever? Now, clinical manifestations. Fever is always in polio very high. It is always present at the onset of paralysis and it disappears later. Okay. In GBS, fever is not common at the onset. Usually they say that 1 or 2 weeks before this paralysis has set in, there is a history of an upper respiratory tract illness, and subsequent to that there could be acute flaccid paralysis in that. Traumatic neuritis could be present before, after or during the flaccid paralysis, and transverse myelitis rarely it is present. Now, flaccid paralysis, how is the typicality or the pattern? Now, in polio, there is acute asymmetrical. It is patchy, okay, and it usually involves the proximal muscles. Whereas in Guillain-Barré syndrome, it is symmetrical, okay, it is bilateral, symmetrical, and more distal. So, the progression would be from the distal to the proximal, from the lower limb to the upper limb. Like that is why Guillain-Barré syndrome also known as ascending paralysis, okay. Then traumatic neuritis. Traumatic neuritis is usually asymmetrical, acute, and usually will be affecting one limb only. And transverse myelitis, it is symmetrical and it usually involves it is mostly the lower limbs which are involved. Then muscle tone. In polio, the tone it will be flaccid or absent in the affected limb. Whereas in Guillain-Barré syndrome, there will be a global hypotonia, means overall. And traumatic neuritis again restricted to that limb only, and transverse myelitis, hypotonia in the lower limbs. Now, how are the DTR, deep tendon reflexes? They may be decreased or absent in polio. In GBS, they are globally absent. That there is the initial stages, there are no reflexes which could be DTR which could be elicitable. Traumatic neuritis, there could be decreased or it could be absent. And transverse myelitis usually absent, first initially absent, and then in the later stages there could be hyperreflexia. Now, sensations. Usually in polio there will be severe myalgia and aches, backache, neck pain, body pains, pain in the limbs will be there. In GBS, usually there will be tingling sensation, pins and needle sensations in the children. And in traumatic neuritis, there is pain at the local area. And transverse myelitis, typically there will be anesthesia of the lower limbs. There will be a classic sensory level. That means there will be a cutoff where there will be no sensations. After that, immediately we will be able to elicit the sensations. So, cranial nerve, this is very classic of transverse myelitis. Cranial nerve involvement. When only bulbar or bulbospinal tracts are involved, then only there will be cranial nerve involvement in this polio. Whereas in GBS, in a variant which is known as the Miller-Fisher syndrome, where there is ataxia, there is areflexia, there is ophthalmoplegia also. So, cranial nerves involved here. And traumatic neuritis often, and usually in the other variants of GBS, the 7th cranial nerve is classically involved. Traumatic neuritis, usually cranial nerves not involved, transverse myelitis also not involved. Respiratory insufficiency. In polio, when there is a bulbar or bulbospinal involvement, then only there will be respiratory insufficiency. But in GBS, where there is a slow and progression from the lower limbs, then the respiratory muscles, upper limbs, it will be quite severe in 35% of the cases. Then traumatic neuritis, usually respiratory insufficiency is not present. Transverse myelitis also same thing. In what about autonomic signs and symptoms? So there will be dysautonomia in polio. In GBS there will be also autonomic changes in form of blood pressure alteration, sweating, temperature fluctuations. Okay, in traumatic neuritis it is rare. And same in transverse myelitis, it will be hypothermia. Now, when we do the investigations, how it will be? Like in CSF, WBC, now this is very important again. In polio, there will be high WBC count, could be normal or slightly elevated protein with respect to the elevated WBCs. But here, the WBCs are less and the protein is more, which is known as the albuminocytological dissociation. Okay, this is classic of GBS. Then traumatic neuritis, CSF will be normal, WBC is normal and protein also normal, transverse myelitis also somewhat similar. Blood dysfunction usually absent here in polio. In GBS, yes, it will be present, but again, like I said, in about 70% of the cases, and it is transient usually. And traumatic neuritis usually not present, transverse myelitis classically present. Now, nerve conduction studies. So, usually in the first few weeks it will be normal in polio and later there will be a delay. Whereas in GBS, because of the abnormal demyelination, there will be a delay in the nerve conduction studies. So same is the traumatic neuritis, but it will be only particular of that particular nerve, and transverse myelitis usually normal. EMG also in polio it will be abnormal. EMG initially in GBS, depending on the recovery, it could be normal in all the other three. Then sequelae, what are the sequelae? In polio, it is usually severe asymmetrical atrophy and the skeletal deformity is developing later. Whereas GBS, it will be symmetrical atrophy of the distal muscles and moderate to atrophy in traumatic neuritis, and in transverse myelitis, there will be flaccid diplegia. Now, surveillance of AFP. Surveillance means there is correction as well as action. What is the main purpose of this surveillance is that all the cases should be detected and reported in an expeditious manner. And the goal would be polio eradication, which is defined as the absence of clinical cases of poliomyelitis for at least 3 years and the absence of wild type of poliovirus in the community. So, usually what happens? Whenever there is any case of acute flaccid paralysis, and it's a suspected case, you have to report the case within the first 48 hours. And then the stool sample should be sent. There should be 2 adequate stool samples which are collected at the interval of 24 to 48 hours and within 14 days of onset of paralysis. So remember, there is 2 samples to be collected, interval is 24 to 48 hours and the time duration is best before 14 days after onset of paralysis. But sometimes if the child is having, like the child is on a ventilator, it is not possible, or if it's at a remote periphery and all, up to 60 days we can take the sample. Then once the sample is sent, you have to act as if it is an outbreak response immunization with active surveillance. Are there any other cases in the neighborhood? And keep following the child up to 60 days from the onset of the paralysis. Okay. Now once the stool is collected, it is sent to a WHO accreditation national laboratory and the report usually after 4 weeks it is available. And then depending on that, the expert committee will decide within 90 days that is it polio, it is polio compatible. What is polio compatible? Polio compatible means the child has either died and they are not able to establish the diagnosis, or the child has been lost to follow up, or the reporting or the samples are not sent. So it could be, or the presence of residual weakness though the samples were not sent. Okay, or if it is completely ruled out, then you discard it and label it as a non-polio illness. So, like I said, it should be the way the stool sample is taken is very important, and it should be placed in a clean container with a wide mouth or a glass bottle screw on the cap. It should not be autoclaved, and usually 1 thumb sized, that is approximately adult thumb, I mean to say 8 grams of stool is required to be sent. And it should be, and this is the national laboratories which are WHO accreditation is there, and it should be at a it should be sent at a low temperature, that is 4 to 8 degrees centigrade they should be maintained in the reach the laboratory, and within 72 hours they should reach the laboratory. So this process of sending from the patient to the national accreditation laboratory is known as a reverse cold chain. We know that what is cold chain then, like from the manufacturer to the patient. The system which maintains the temperature and all that is regularly the cold chain, but in reverse cold chain what happens is from the patient to the laboratory in the opposite direction. So the two samples are sent in 24 hours apart within 14 days of onset of paralysis, and like I said, it should be within 72 hours they should reach the laboratory, and if it's not possible to send it like that, you can even freeze it at minus 20 degrees centigrade. So now a case has come, so how will you clinically approach it? So if there is an intact sensorium, it is less likely. Now we are talking about the clinical approach. Okay. So AFT surveillance is over. We have defined it. We have looked for the causes. Then we have seen the 4 major causes. How to differentiate them. Surveillance we have talked. How to send the sample. What is reverse cold chain we have talked. Now we are going to talk about the clinical approach. How will you know where is the lesion? Okay, and how to suspect. So if the child is having an intact sensorium, that usually differentiates hypotonia. Usually it will be a lemon lesion. Usually it could be either at the anterior onset axon, neuromuscular junction, or the muscle. Then just if it is accompanied with a cranial nerve involvement along with this and an intact sensorium, but still it is always better that you do MRI to evaluate other causes. Then there is a sensory level which is present. Spinal tenderness, gallbladder involvement. Look for the cord, and tonal reflexes are reduced. Look at the spinal cord. It could be transverse myelitis, epidural abscess, TB spinal cord ischemia, or any other vascular pathology. Observe the child also. As the child is brought to you, if there is any head control, there is a head lag, how is his breathing, how is his posture, is there any difficulty in speech, is there any difficulty in swallowing, are there any pooling of secretions in the mouth, okay, and is the child able to bear the weight on his legs, or he are unable to turn, or is he able to reach out to the toys and all. So in the history what I say is, you have to first, how will you talk about elicit the history? You have to elicit when you are eliciting whether it is unilateral or it is generalized, whether it is proximal, whether it is distal, or how will you know proximal and distal? Supposing if the child is not able to hold anything, he is not able to hold a glass, he is not able to hold a pencil, that all would be distal. Then if it is proximal, he is not able to use his arm and reach out to the object, he is not able to get up from the sleeping position, so truncal weakness, from the recumbent posture to the sitting posture or standing posture he is not able to, then it will be more of a proximal muscle. Then he is not able to maintain his posture, so that is more of a proximal muscle weakness. Then you have to ask if the child is if anybody else in this family is suffering from any such illness, if the child has had any honey or a canned food, look for any botulinum toxin. Then you have to ask whether on doing particular tasks the child is having a decremental risk or getting fatigued by performing the tasks. Then it could be a myasthenia gravis, or more it is in the evenings, or if the child is having any features of cranial nerve palsy, that he is having ptosis, or he is not able to move his eyes, or he is not able to blow, or he is not able to smile, he is not able to chew. So you can ask for cranial nerve palsies in that manner. Then you have to ask about any recent vaccination that the child has undergone. Like it could be, especially in GBS we have worried, like if he has undergone any recent vaccination with any of the rabies vaccine or any other vaccine, like or in polio, if it is he has taken a oral polio vaccine, and it could be a VAP, that is vaccine associated paralytic polio. So all these things you will ask the history, and then you have to ask about autonomic features. How is he, like having any urinary bladder retention, or he is having sweating? Does the mother feel that there is an increase in the heart rate? So you can for such features also by history. So, depending on the weakness, whether it is from the motor neuron or the peripheral nerve, depends on the evolution of symptoms or signs. Usually, symptoms from the neuromuscular junction and the muscle, it will be acute, like periodic paralysis. It may be acute, like it's at the level of the muscle in a few minutes or days. Then family history, like I said, anybody else in the family, it could be a familial periodic paralysis or a porphyria or a metabolic myopathy, history of vaccination that we have already told, GBS, polio, transverse myelitis, any drug ingestion, any gastrointestinal symptoms like in vomiting, loose stools. It could be in children there could be hypokalemia which can give rise to this weakness, or it could be, like I said, canned food or the honey which can cause botulinum toxin, or any poisons. We have to ask history of any poisoning like a snake bite, or it could be a organophosphorus poison. Then pain. Now the pain will be, it differentiates from the others, like there will be a neck pain, back pain, myalgias, which is classically seen in case of polio. Then pattern of the weakness, like we said, it is symmetrical, asymmetrical, or only polio is asymmetrical, and the other like GBS or will be symmetrical, and it would be asymmetrical. Any bulbar function is the dysfunction. So, commonly seen in case of diphtheria, polio, and some variants of GBS. Then if there is any ptosis or ophthalmoplegia, like I said, in GBS, Miller Fisher variant can present with ptosis and ophthalmoplegia, mainly ophthalmoplegia. Then look for any pupillary changes, especially commonly seen in organophosphorus poisoning. Then how is the pattern of weakness? Is it flaccid, or initially it is flaccid, and as it is progressing, it is becoming spastic? You have to observe that it, because if it is initially flaccid and then it is progressing into spasticity and all, then we would think of any cord lesion like transverse myelitis. Any retention also, bladder bowel dysfunction also, you have to rule out spinal cord pathology. Then management would be including stabilization of the patient, attending to the ventilatory needs, physical history and physical examination. Then whether the child requires any ICU admission, because if what is the criteria for ICU admission would be a vasomotor or the respiratory insufficiency, rapid progression of the disease, bulbar symptoms, suspected poisoning, and acute severe illness. Then laboratory investigations would be routine and specific investigations like CBC. There could be leukocytosis in case of a systemic illness, and ESR can be elevated in certain autoimmune disorders. Then CPK and aldolase in muscle diseases. Then elevated blood urea nitrogen, mainly in the rhabdomyolysis and renal insufficiency. Then electrolytes, especially mainly looking at hypokalemia and hypomagnesemia in case of periodic paralysis. Then thyroid assay for any thyroid myopathy. Nerve conduction studies, this is very important, and EMG, that is electromyography, mainly in case of GBS and other myopathic disorders, and repetitive stimulation in case of myasthenia gravis. Then MRI and CT scan of the brain and the spinal cord, especially in cases of transverse myelitis and other cord lesions. And lumbar puncture, like we discussed in GBS, that will be classic albuminocytological dissociation. Now, Guillian-Barré syndrome, we will be talking about it in short. It is a presentation which is characterized by an acute or monophasic. It is an acute monophasic or non-febrile post-infectious illness manifesting as ascending weakness and areflexia. So this is the normal nerve, and this is the myelin sheath. So here the myelin is damaged. So this is what happens in Guillian-Barré syndrome, that there is damage to the myelin which occurs. So what is the pathogenesis? There is an increase in data which indicates that it is an autoimmune disease often triggered, which is by a preceding viral or a bacterial infection. Especially the organisms which are the causative agents would be Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, and Mycoplasma pneumonia. Then there are two types mainly, demyelinating form and the axonal form. The demyelinating form of GBS, which is seen in acute infectious etiology, that is segmental demyelination of the peripheral nerves due to immune-mediated response involving both the humoral and the cell-mediated organisms. Now, cell-mediated mechanisms. So, here there it is immune mediated, and there are antibodies which are generated which cross react with this myelin sheath and then cause disruption or conduction dysfunction or block. Okay, so once these antibodies they destroy the myelin sheath and there is a local response, complement is activated and macrophages get activated, they engulf all these other immune-mediated so there will be a conduction dysfunction and block, and subsequently there is a repair which occurs and then there is a spontaneous recovery. Axonal forms of Guillian-Barré syndrome may occur without any demyelination or inflammation, and like we said, this is demyelination where the antigen is unknown and antibodies they cross react with the gangliosides of the nerve, and then there is complement activation, nerve injury and macrophage scavenging of the myelin sheath. So here in other variants there are specific antibodies like GM1 and GM1A where there is an axonal loss. So, which cause axonal loss, and in the Miller-Fisher variant, the specific antibodies are GQ1B antibodies, which mainly act at the muscle spindles. So, compared to the acute onset or the demyelinating forms of GBS, these two have a poorer prognosis, and mainly the axonal loss, especially the acute inflammatory demyelinating polyradiculopathy. This is the common one, and the prognosis is good. Like we said, the antigen is unknown and that causes the antibody production, and there is antibody binding, complement activation, nerve cell injury and macrophage scavenging, but eventually there is it is self-limiting. But in the other variants there is an axonal loss which takes place, acute motor axonal neuropathy. So this takes a very long time to recover, and acute motor and sensory axonal neuropathy, this has got a very bad prognosis. The Miller-Fisher syndrome, like we said, it is class, there is a GQ1B antibodies which are mainly generated, and there is one variety of GBS which is associated with cranial nerve palsy, 7th cranial nerve, which is known as poliovirus cranialis. So here in Miller-Fisher syndrome, the oculomotor, trochlear and abducens are affected, and there is a triad of ophthalmoplegia, ataxia and areflexia. Okay, and when you do the antibodies, there are classical antibodies against the autoantibodies against the gangliosides, which are present mainly concentrated more in the nodes of Ranvier. It is GQ1B and GT1A. So GQ1B is specific of Miller-Fisher syndrome. Then a variety which is known as the poliovirus cranialis, which is also a bilateral 7th cranial nerve palsy with a sparing of first and the second. So there is elevated CSF protein, slowed nerve conduction velocity and uncomplicated recovery. So on physical examination, an ascending motor weakness is noted along with areflexia in the classic form. Areflexia is the hallmark of GBS. Occasionally, some of the more proximal reflexes still may be elicited in the early phase of the disease. So there will be around 26% of autonomic instability, 23% or 20 to 25% of in attacks. There could be association with ataxia, then transient bladder involvement and other cranial nerve involvement. Predominantly facial palsy, 50% of the cases. Then it could also, initially it could present as a leg weakness or foot drop in the initial weakness, which is seen, and eventually it progresses to calves and the thighs. Later on, the respiratory muscles and the upper extremities may show involvement. Then physical examination, we are continuing with that autonomic dysfunction, like in there could be orthostatic hypertension, pupillary dysfunction, sweating and tachycardia. So mainly to diagnose GBS, the thing is progressive ascending weakness and areflexia. Whereas in laboratory there could be, when you do a lumbar puncture, there will be classic, like I said, albumin cytological dissociation. That means the cells are normal or less than 10 and the albumin or the protein will be substantially very high. Okay, usually the cells and the protein go hand in hand, but here it will be reverse. Electrodiagnostic studies, like I mentioned, nerve conduction velocity as well as EMG. Nerve conduction velocity will also help in differentiating the different types of GPS. And the occasionally, if required, we have to do. Then and serum ganglioside antibodies. So in GBS, if it is not a classic variant which is present at the acute form, if you are suspecting the other, especially the Miller-Fisher variant, you can go and perform the serum and anti-ganglioside antibodies. And like we said, GQ1B, that is most common, and these antibodies are also found in association the GM1, GM1B, GD1A and all, which are more common in the axonal type of neuropathies, have been associated with Campylobacter jejuni infection, and and presence of such antibodies will prognostically tell us that there is going to be a more severe cause and more residual neurological defects. Then, like we said, they discuss the differential diagnosis. It could be at the level of the spine, that is transverse myelitis, epidural abscess tumors, then some anterior onset defects like polio, then vascular malformations, cord compressions. Then, like we already discussed at what level the lesion could be. So, treatment, when you are coming to the treatment, treatment is mainly immunoglobulin and plasmapheresis. So, what is the dose of immunoglobulin? It is 400 milligrams per kg for 5 days, or you can give 2 grams per kg for 2 days. So, studies have shown that both are equally effective. And in case of the severity is more in the child than into respiratory insufficiency, there's a rapid deterioration, you can even think of plasmapheresis. Complications. The most serious complications is mainly because of only 2 things. One is there is a weakness of the respiratory muscles, and second is autonomic instability. And the other associated complications would be an aspiration, pneumonia, bladder dysfunction, infections, pressure sores, pulmonary embolus, constipation, nephropathy, which could be associated with the main illness, main complications. So what is the mortality? The mortality in acute type is very less. So it is less than 5%, and the cause is usually because of respiratory failure, cardiac arrhythmias and dysautonomia. But the chronic forms of Guillian-Barré syndrome, which can which are slowly progressing, and they keep on progressing intermittently, they have got a very bad prognosis. And like we said, acute motor and sensory neuropathy, that is also called and the presence of that other anti-ganglioside antibodies can also cause a poorer prognosis. Okay, so we have come to the end of this lecture. So like we said, in acute flaccid paralysis, what I would like to revise is how will you take the history. So how do you approach a child with acute flaccid paralysis? So first thing is history. So what are you going to ask in the history? Then your examination. So what are you going to find in the examination? Then what is your diagnosis, provisional diagnosis, differential diagnosis. Then in the differential diagnosis, between acute flaccid, between polio, Guillain-Barré syndrome, traumatic neuritis and transverse myelitis, you have to be very clear. Okay, then comes your investigations, and investigations you are going to narrate everything, like from the right from the AFP surveillance to the lumbar puncture, everything. Like we have discussed, the routine investigations, the specific investigations. After that, we have to write about the AFP surveillance also, and how we have going to send the student a reverse cold chain. So this is the way we have to read and approach the case of acute flaccid paralysis. Thank you.